So my name is Christophe Sarva, and I'm the academic director of iCAAD, and introducing this next conference. I'm really thrilled, Mike and Jack. All this started a bit in Paris a few months ago when we were all together conferencing there for iCAAD, and I'm really thrilled this conversation is happening now in the UK. We are again at turning points when it comes to how to protect our communities, how to help people in pain when we name addicts, how criminal justice diversion into drug and alcohol or alcohol treatment can work. How are we doing is the question that Mike and Jack choose. I Googled addiction. Out of 85 million answers, a good 65% are about morality, sins, criminal behaviors, bad behaviors. A small 15% about treatment. Speaks volume. Prevalent mindset in our community is that it's bad behavior, it's out of flow, it has to be punished. It informs our belief structure, it informs our society, it informs our politics. It's very sad because, as Jack said in Paris, mental disorder is not a crime. That's true. Every 4 minutes someone is dying from an opiate overdose at the moment. This is not a crime, that's a death, that's pain. And it came to my thought the other day listening to you guys in Paris that in criminal justice language, what we call prevention means no reoffending. And in the mental health language, prevention means getting better, not getting unwell. There's a huge gap for the same word here. So how are we doing? To discuss that, two international experts, one from the UK, one from the US. And let's see what happens into this sharing conversation. Mike Trace, CEO of Forward Trust, former CEO of Wrapped, ex-Forward Trust, Blenheim Project, former chair of the CDDA in the European Union, former deputy UK anti-drug coordinator. Thinking of who else could speak better about what we did over the last 20 years here and what can happen, I came up with a blank. It's you and only you, Mike, I think. And now comes Jack. Jack has just landed, so let's be very forgiving for his jet lag. A couple of hours late in the flight, so it's a blessing you're here on time. Jack just arrived literally 15 minutes ago from the US into this building. So Jack, passionate about pre-arrest diversion, alternative to criminal system. From Chicago, national director at TASC and PTAC in the US, big into putting in place with law enforcement, criminal system, attorneys, alternative system into the systematic arrest, which prevailed in the US since Nixon, Reagan, Bush, carries on with Trump, I'm afraid, right? So two angles, two visions, same language. And when I say same language, I'm not speaking about English. I'm speaking about the language of empathy, the language of kindness, the language from the heart. And it's in English, by the way. Yes, absolutely. Okay, so the floor is yours. Thank you so much.
See you later. Okay, does this work on from here, or do I have to stand there? You can hear me on the microphone, okay. Yeah, I'm one of those people just introduced, Mike Trace. I'm Chief Executive of Forward Trust. Many of you know me. What myself and Jack thought we'd do, and Jack, as I say, literally is straight from the Heathrow Express into the room. So I'm going to do a few minutes, pad it out, just until you're settled there. What we thought we'd try to do, we've come across each other last 6 months and found out that we do have a lot of similar language. I think I like what Christophe said, is a language of actually having empathy towards people who end up in the criminal justice system. And the question we thought we'd cover was criminal justice diversion to drug or alcohol treatment. How are we doing? From my point of view, and it'll be obvious to you that I've been doing this for a long time from the introduction, the basic concept of saying that a large number of people who are struggling with their drug or alcohol use or struggling with other aspects of their life end up in police stations, in court, or in prisons. And it seemed to me a no-brainer, even when I was a kid, that you react to that with empathy and find ways of responding to those people to say, how can we help with resolving your problems, rather than piling on to those problems with punishments and stigmatization. So that basic concept has been floating around the drug policy world for decades. Yeah? In the US and the UK, we have put a lot of attention into that concept. What do we do about it? How do we make it possible to prioritize recovery over punishment? We need to really take stock and say, well, with all of that effort and attention, what have been good ideas, what have been bad ideas, what have been things that worked, what are things that haven't worked. We're a little bit worried, myself and Jack, that this might be too technical a presentation. We don't want to make it boring for you. We don't want to run through loads of statistics and system and flow diagrams. So we're going to try and make it as interactive as possible. Those of you who don't want interactive, please leave now. But we've got our flow of discussion that will do a double act up the front here, but we're both going to sort of turn to you, the audience, at various points and say, what do you think about this? Because there's a lot of history here. There's a lot of ideas in this presentation, and we don't just want to spout them out to you. We want to hear your views as well. So to help us understand who we're presenting to, I'm going to ask you to do this, Jack. It first helps to find out what the audience made up of, yeah? What type of professionals we're talking to, what type of life experiences. So Jack will have thought up on the plane a few categories and is going to ask you to put your hands up for which category you fit, so we know who we're talking to. So over to you, Jack.
Sounds good, Mike. Thank you. And by the way, the reason we are seated over there and have to come over here, because this is the only place that has the camera. So we're doing exit stage left, right, back and forth. So that's why that looks a little bit odd. The camera's only over here. Good afternoon, everybody. My name is Jac Charlier, as Christoph and Mike said. And I landed, I got to the hotel about 17 minutes ago. And I woke up yesterday at 6 a.m. in Chicago. So it is super cool to be here. Played rugby for many years. And every time I come back to England, I am very thankful for this, one of the many sports that you gave us in the United States. So let me just tee off right where Mike was. We want to know who's in the audience. So I'm going to ask you by show of hands, who here is doing treatment, wherever you're doing treatment. So who's doing treatment, any kind of treatment? Let's see, so that looks like the majority. Is that all in the U.S. we say substance use disorder, drug use, drug abuse? Is that all that, or any mental health? Okay, good. Who is here from the criminal justice system? Okay. Oh, you guys are all in back. Typical. And you're all together. Typical. And you have your backs to the wall. Typical, right? Exactly, right. And that's true all over the world, having come from the law enforcement world. Prosecutors, police, what arena of criminal justice? For those who raise their hands, what arena of criminal justice are you from?
I'm a nurse in the prisons.
Okay, prison. Are you guys all prison system then? Okay, good, yes.
12-step residential rehab.
Okay, cool. Post prison.
Then a lot of our referrals come straight from custody, so we pick them up and then go to the treatment centre.
Okay, cool, super cool, good. So we've got some criminal justice, we've got some treatment. Do we have any elected officials here? I don't know what you call them in the UK. Elected members of parliament, local councils, MPs. There we go, MPs. We call them something, but in the U.S., but we're on video, so I can't use that word. Good. Do we have anybody here then who represents community, just kind of citizens who are in recovery, part of the recovery community? Very good. Good. Also, cool. Anybody we didn't call? So we have mostly treatment, some corrections. Yes.
I work for Release.
For Release.
Like a drugs charity, we provide them legal services.
Okay. Cool. So legal aid of some sort. Good. Okay, that sounds good. So that's good to know for the audience, and Mike and I will adjust then our presentation and lean a little bit more to treatment, but understand that there's corrections folks here and others, obviously. We'll talk a little bit about that also. Is that good? Cool,
Yeah.
so good. Yes, oh, we got a question already.
Yes, I'm from education.
Oh.
Personal, social, and health education
Okay.
of young people. So.
Okay, very good. Do you interact with either the criminal justice and or treatment?
Yes, social services fell to me on offenders for working with young people who are getting into trouble on the street, etc.
Okay.
That would be really helpful.
Yeah, very good. One quick question on the folks who are here from treatment. How much intersect do you have with the people you're working with? How much intersect do they have with criminal justice? Because that's what Mike and I are here to talk about, but just because you're in that doesn't mean that's the case. So just, we need the mic because you guys are on for posterity, right? So this is recorded until the planet explodes or something like that.
Hi.
Yes.
Yeah, with all the cuts and stuff, a lot of the community services actually now got the DIPs within this, like drug intervention programs, which are criminal justice within their services.
Okay.
So there's lots of a lot of interface with the police and the prisons.
Okay. You're in a community treatment setting, though, so you could see anybody else could come to you also, though, right?
Yeah, but we do have a lot of court orders and stuff also.
Okay.
So yes, it's the whole of the borough.
We'll be talking about the DIP program in later slides, so you'll be able to contribute then, I'm sure. Yeah.
Yeah, I thought you called me a dip. So this is when I'm like, okay, one of these translation things. Anybody else in treatment who does not have a big intersect with criminal justice? Hold on, you gotta wait for the mic.
Does not.
Does not. Yeah. You do not then. Okay.
do.
Oh, you do. Okay.
He's-
Yeah. Who
he's a
does
yes.
not?
But we do.
Okay. All right. So I know Mike said we aren't going to get too technical. In the U.S., our justice population, which is right now at about 7.2 million people under some kind of active justice supervision, probation, parole, prisons, jails, and about 68 million Americans out of 350 who have some kind of criminal contact. But of those under justice supervision, about 60 to 80% have substance use disorders that are diagnosed, right, clinical along the way. So very high percentage, which is why I wanted to ask you that question. 30, 50% mental health diagnosed, and then about a 40 to 60% overlap co-occurring, as we call it, of the two. So our justice population probably looks a lot like yours. Lots of disease, lots of trauma, lots of homelessness, women, sexual assault, all sorts of things going on. And the men too, as we're coming to find out. And then also the people who commit crimes also have in their background lots of things that have been done to them. So does that sound like what you've got here then, Mike?
Yeah, just smaller numbers.
Yeah.
So we've the equivalent figure I don't have actually access to, but it is in the region of 400,000 people under some sort of criminal justice contact at any one time, and compare that with 7 million, it's proportionally higher.
Yeah.
With the we'll look into the
Sure.
the scale later on. We've asked you who you are. We've able to tell you who we are. Christoph's done his introduction, but just a little bit more on myself and Jack. As Christoph has mentioned to you, I've been around this field a very long time, and most of the work I've done over nearly 30 years has been somewhere around the criminal justice system. Worked in prisons in the 80s, when prisons, believe it or not, were worse than they are now. If you work in prisons at the moment, that's hard to believe, but generally did early drug work in the prisons, and have been around organisations like RAPT, Forward Trust, and those who remember RAPT even before it was RAPT, called Addictive Diseases Trust. You can tell why we changed the name, back in the 90s. So I've worked around the criminal justice system, substance misuse, for the best part of 30 years. When I've worked in government, I've done government jobs as well. I've usually tried to promote what we're going to be talking about here, which is, as far as possible, use the instruments of the state. If you're in touch with people who are in conflict with the law, the first thing you think about is what's driving them to this behaviour and how can we help, rather than how can we punish and how can we feel good about that. So that's been an issue for the length of my career. My current job, as many of you know, I run the Forward Trust, and we try and stick as close as possible to our mission, which is give anybody in the criminal justice system the chance to make changes in their own lives and fulfil their potential. So that'll be resonant on a lot of the things we're talking about here.
Yep.
And you, Jack.
Yeah, real quick. So my background actually is not clinical or treatment. I actually come from law enforcement in the United States. And I have a very quick story that I tell of how it is that I ended up in this world then of bridging. We call it bridging criminal justice into behavioral health. And it's quite simple. Got out of the academy, went to work in Chicago in an area that's very economically depressed, mostly African American, and lots of poverty, lots of issues attended with that, a lot of racial impacts that have happened in the communities. And after a few years, I realized the tools I had been given to fight crime were having almost no effect whatsoever. Right? I could see that it just wasn't doing anything for the vast majority of the work that we were doing. And so I began to educate myself And I take no credit in this other than knowing that I didn't know very much about how to actually fight crime. And so I began to educate myself by going to places that had mental health services, that had substance use disorder services, that did trauma and counseling, and said they must have some slice of the solution that's needed here, or they wouldn't be in the community doing the exact same thing I'm doing, except for I have a gun and a badge and a vest and a radio and a squad car, and I get to do this all kind of cool stuff, but they're here too doing their work. And so my journey from kind of a very strict law enforcement background, law and order, which is a very kind of our cultural makeup in the United States often, to where I am now standing here with you with Mike, really is this journey of understanding how do we actually reduce crime. And we do that, and you know what I'm about to say, by making people well, right? By helping people get well and stay well, and that means healthy, not just in recovery, not just people who have mental health treatment, but helping them get well if they're not well. That includes all sorts of things that have nothing to do with a gun and a badge. Housing, you know this, mental health services if needed, drug treatment, recovery, peers, coaches, all the stuff that goes with it that I don't need to get into. So for me, my transformation is gun and badge to not being clinical, but to understanding how to bridge these worlds so that people get well. And what I say to U.S. audiences all the time, to the public, is we have 40 years of research in the United States that tell us that when people get well, they stop committing crime. And when people stop committing crime, it's good for them, it's good for the communities, it's good because we have less crime victims. So I'm really focused on crime reduction. And I say that to all of you, especially in the treatment arena, but whatever brings you here today, you are part of, as I understand it, of the crime reduction work that goes on in the world. It just doesn't get the same attention as I got when I had a gun and badge, right? In the U.S., that's a big deal to be like a police officer. It's a big deal. We elevate them, we highlight their work substantially. But the work that you do, many of you in treatment, is out of sight, out of mind, poorly funded, in the back rooms, you know, and that's it. And yet you guys hold the key, a large part of the key, I should say, to how it is that people like me who come from law enforcement can actually be successful. So that's a little bit about my journey that brings me here today, and I am always so thankful when I speak to treatment audiences for the work that you do day in, day out, often unnoticed, at least in the U.S., unnoticed, underpaid, underappreciated, and yet without you, it's not happening, right? It is not going to happen because we're not going to get folks to be well.
Right, and so you've got a representation at the front, somebody from a treatment background, somebody from a law enforcement background, exactly the same analysis, exactly the same ideas.
Yeah.
So that's why we thought we'd be useful for you today.
Yeah.
What we're going to try and do now is operate the slide system. And I'm just going to reiterate what we're saying, that is we do not want to give a technical long lecture, so please do put your hand up at any time, ask your questions, take us off at a tangent, talk about your own experiences. That's what's going to make this session interesting, because it sure as hell isn't going to be us two.
Well, it won't be Mike. It'll be me. It won't be Mike.
Sorry, I shouldn't speak for Jack. Yeah.
I got lots of Diet Coke from the airplane in me, so I'm good.
Okay, so we're going to start with a flow diagram. As I said,
Yeah.
you're not doing any, and I just want to start from the phrase at the top. Where this starts is, as I say, a lot of people come into contact with police, courts and prisons. Nobody plans to. Nobody sort of says, I want to get arrested, I want to end up in there. But many people that we want to help end up in contact with those services. When I went into government in the late 90s, that basically was the truth and the policy position we wanted to react to. Say, okay, you know, there are hundreds of thousands of people in the UK who end up going through this sausage machine, and what should we be trying to do with them? And what you can see there basically is what we're referred to as off-ramps, is we need processes at all stages of that system to take any opportunity possible to divert people away from the path they're following, but also the path that the criminal justice system churns them through. You know, you've got to turn up for your appearances. The police have got to surrender to the police. You've got a bail hearing. You've got a sentencing hearing, a case. Then you go into prison. Then you come back out. All of those, that what I call the sausage machine. At any stage of that process, there are off-ramps. So, Jack, do you want to say a little bit about? It's your slide. You have a look at what those off-ramps mean.
Sounds good. I brought it from across the pond, as we like to say, so it's good. So notice up here what I said in my opening. You are the folks that I really look to for the power of the intervention for crime reduction and well-being. And so notice it's diverting people into treatment and services. Tell me some of the things you are doing in these off-ramps if you're working with the justice system, right? And these off-ramps are related to the part of the continuum that you're at. What are some of the services that you are providing? Help me understand that from where you are, that you're providing to folks in the justice system that are helping them get out of the justice system, get better, and in getting better, get their lives on, not do crime again, no more crime victims, get a job again, get with their family. What are some of the things you guys are doing? And assume I know nothing on the clinical side, because I'm not from that. So you may say something very simple and say, well, everybody knows that. So it's totally fine. Yes.
Okay, so we, the organisation I work for, provide quite a number of supported housing, abstinence-based supported
Excellent.
housing for offenders coming out of custody, and they can come and reside in our houses for up to 2 years and more,
Yep.
where we sort of loosely encourage, but there's an expectation that they'll be engaging in purposeful activity, college training, education, voluntary work to develop the life skills they need, A, to manage in independent living, but also the majority of ex-offenders are coming out with no work history, no qualifications,
Right.
no driving licences, no skills, and given the environment, if you're coming out to nothing, you're more than likely to go back to what you know.
That's correct. Yeah,
On the
that's
street.
correct.
So we provide just over 30 supported houses in London. We work very closely with the Forward Trust. So we're kind of at the end of that.
And the-
So they're coming out of prison, basically. So we're
Okay.
not really intervening anywhere before that kind of pathway, if you like.
That's excellent.
And it
excellent.
works really well.
Would you rather, Nick, if, and you're allowed to name your organisation, adverts are okay.
Yeah, it's Kairos Community Trust, so
Yeah.
which is a Greek word for the right time for change.
What's the word?
Kairos.
Kairos, okay.
Remember that.
I'm American, remember, we only speak American. We don't learn other languages. Because we have no need to, because the whole world speaks American,
Well,
right?
stops on the East Coast.
That's right, exactly.
So my role, having previously worked for the Forward Trust for 9 years, delivering and managing drug treatment services in prison, which is fantastic, and the guys do really well in a custodial setting. It's the through the gate stuff. So
Yes.
when they're coming out, what they're walking onto. So I do a lot of assessments in a lot of prisons during the week, and it's giving them the opportunity to come into a safe environment with like-minded people where they can develop the skills they need.
That's
to move
excellent.
forward.
So you're,
Yeah, that's
Nick,
excellent.
basically, you're that stuff, aren't you?
Yeah.
These arrows up here, that's where it
Yeah,
goes to you.
we're
yeah.
kind of preventing that re-entry back
Yep.
to prison and that cycle of addictive behaviour and criminality, basically.
Excellent.
So,
I love what you said about housing. So in the U.S., and maybe you know this, we have a model called Housing First. I don't know.
Yeah.
It's just, yeah.
It's getting fashionable over here.
Yeah, Housing First, it's a Corporation for Supportive Housing. CSH is a national organization, and they helped develop that. They weren't the ones, they helped develop it. And it's this real simple idea, right, that if you stabilize someone in housing, forget even providing them services, but mentally, Maslow's hierarchies of needs, right? Just
Yeah.
give them a place that they can feel safe. And I don't say this to be funny, but I grew up with cats. Cats love going in boxes. They feel safe. Out of the boxes, not as much. So you just give people kind of a box to be in that's safe, already does wonders to stabilize them to be able to access services.
absolutely.
Yeah, so it's excellent. I love that you mentioned housing. How about somebody else? An aerial, off-ramp aerial diversion, and where? So tell us where you are in the justice system, and then what services you provide.
No, I'm not in the justice.
Okay, that's fine. Yeah.
Yeah, I'm a psychiatrist.
Okay. Oh, good.
So, yeah, I think we reduce the re-entry to prison.
Yes.
So we used to see them, for example, I'm working in substance misuse. We got a call from the prison that they will release him today, for example. Then we'll be ready to see him the same day. Sometimes the clinic is ending at 5 o'clock. If there's prison release, sometimes we wait till 6 o'clock.
Yeah.
We call him, we make sure we give him the right dose, we make sure we do the risk assessment, and we put him in medication. He has mental health issue,
Yeah.
a mental health assessment.
Very good.
And that's in a community prescribing clinic, yeah?
This kind of-
Okay.
Good. And is that psychiatric medications then? Because yours, that's right. Okay.
If substance misuse, we'll provide methadone or
Yep.
opioid substance, or if it is
Yep.
mental health, we'll try to make sure that they are in the right dose of antipsychotic,
Yep.
and they are compliant with the medication.
Yeah. One of the big problems over here, I don't know if it's the same in the US, is continuity when people come from
Yeah.
the community into the prison and from the prison back to the community, because our system isn't predictable. I don't know
Yeah.
in the US, so you could get people released from prison at short notice,
Yeah.
and the services don't know if they're coming or not.
Yeah.
And the other way around, people
Yeah.
arrive in prison late at night, and it takes a while to get them in touch with services.
So let me ask you a question then to help me understand, because here you have National Health Service. Whatever you think of that, we don't in the U.S. You're kind of on your own. You might get insurance through your employer. Most of the justice population, up to 70%, has no insurance at all. They have no health insurance, so they walk out with nothing unless they have dependent children, for example. The men leave, so the women almost all have it because they're left with the kids. Because, Mike, we leave, right? The men leave. Yeah. But the men who are 80, 85, 90% of our justice population have no insurance. So how do you do medications here? You have the ability then, because everybody has National Health Service, to just keep accessing it?
Yeah.
Okay, that's great.
We don't have that problem.
You don't, you've got other ones, but we have that one, yeah.
Like continuation, But
Yeah.
I like the day of the release, I guys just run away and start using again.
Yep. Well, yeah, that's right. That's abstinence to know, that's what that is. Yeah.
If it's a medical service, you're covered by the NHS, so
Yeah.
no questions are asked at a clinic
Yeah.
to say, are you resident or anything.
Yeah, that's
If it's
excellent.
social care services, you have to prove you're a local resident. Yeah.
Well, we do that easy. We have no social care, so it's just easy. You're just kind of on your own in the U.S., yeah. All right, very good. Anybody else? So thank you. How about one more, and then we want to keep going because we have like 2 interesting things to tell you, and we want to make sure we get to them. Yeah. Good. 1 and then 2. So yeah, where are you on the continuum, and then what kind of services?
I think we're beyond the dotted line, I hope. Fingers crossed.
Yeah.
My name's Mark. I work for an organisation called Steps to Recovery.
Uh-huh.
We're a very, very small treatment centre, and we sort of fill the spot in between prison and what Nick has described, Kairos, when working with people who are very, very entrenched or have been very entrenched in their addiction. But we're working with people who are motivated to deal with that.
Yeah.
So we're not a detox. We're what's called secondary treatment. We offer our clients a very rich program of group therapy work, one-to-one counselling, and all sorts of other therapy as well.
Mm-hmm.
And then these clients who would otherwise probably be homeless are then guaranteed housing via our relationship in the chain with Kairos, with Nick's organisation.
That's excellent, yeah. That's excellent. Good.
Good. We're free.
You're free, good. We'll take your cards back to the U.S. and just get people over here.
We're free. We raise all our own funds, and
Yeah.
we don't have any statutory or government funding at all.
Yeah.
So it gives a degree of independence, and I like to take slight issue with. I was in prison in the 80s, and in those days you could get 2 tins of beer on a visit.
Yeah.
Which you can't today.
Yeah,
so
it's gone downhill.
It's gone downhill.
I love that.
It was a different type of chaos in those days, wasn't it?
Yeah.
I was going to say, I said the reason that we are free of charge is that if you're leaving prison and you want treatment, you have to apply for funding, and put very, very simply, you have to go through an assessment of the community.
Sure.
And that assessment can take an awfully long period of time. It can take up to 3 months.
Yeah.
And you're leaving prison with a cheque of £47, possibly nowhere to live, returning to the same environment.
Yep.
And that motivation that you had at the point at which you're leaving prison can disappear fairly rapidly.
That's right.
So we bypass, it's a challenge for us, but we bypass statutory funding, raise our own funds, and take people directly into treatment from the prison gate before they then move on to the next organisation.
I mean, it's impressive what Steps to Recovery are doing, because the willingness of the public sector to pay for placements in a place like those has been going down for years.
Yeah.
And one of the criteria for released prisoners is that some local authorities say a released prisoner has to come out and show that they can maintain abstinence before they're allowed to apply to the residential centre, which is kind of, well, if you can maintain abstinence, you might not need the residential centre.
Right, exactly.
And if you can, then you won't
That's
make
right.
it. You know?
Yeah.
So it's gone a bit crazy. I think that's going to be a theme of the afternoon. There's lots of good
Abstinence
ideas.
or bit crazy?
Which
one?
bit
Which
crazy.
theme? Okay, I didn't know which one was the theme.
I'm not committing to either.
That's it. Not committing, good.
But there's lots of mismatches in the system, which I think we'll try and explore later. There was one at the back.
We'll do one more, and then we've got to get going to get to our 2 interesting points for today. Remember, there's 2 interesting things. We've got to make sure we get to
Stay in
those.
the room.
Yeah.
So, okay, I work in one of the residential rehabs that's in Hull. I work for Forward. So we get referrals that can come from custody. But we also work with another organisation in the community as well called CGL. And in that service there's, I think round about now, and Mike will know, something like 2,000 to 3,000 clients. So within that service, part of it is criminal justice. It's been joined now. So in the residential rehab, they will come to us from custody. They would began doing some case management and group work within the prison, and then they'll come to a residential rehab. And what that will provide is obviously a safe place.
Right.
They can begin treatment in the residential rehab. They'll get peer support. They'll get counselling. They'll get one-to-one sessions. So that's kind of what takes place in the rehab. But in the service in Hull called Renew, we work alongside another organisation called CGL, and in that service we provide things now in the community as well. So there'll be groups across the city which will be stepping stones, foundations of change, other groups as well, so they can access the type of treatment now that's been provided in treatment centres in the community.
Excellent.
You know, case management, it's a prescribing service. You know, we're doing really well in Hull at the moment, and Mike obviously knows about that. You know, and in that service there's education, training, employment workers. You know, there's specific groups for wherever you're at in your journey. There's prescribing if you need it. So when you come through the service, it's like, right, here's the introduction to service group. What can we do for you?
Right.
Not what we're going to give you. What can we do for you? How can we help you? You know, what do you need? And that's kind of the wraparound service that's involved in Renew. And then in the residential rehab, obviously the guys come there. They can be there for primary treatment and secondary, which can be 3 to 6 months. And in that process, while they're in the treatment centre, they can begin looking for housing. They'll be supported in that, supported in if they want to look for, you know, new education, training and needs. You know, supported with the mental health if they need the, you know, the Let's Talk service. So there's a lot of wraparound support in the residential rehab and also in the Renew service as well, which we work alongside CGL in that service.
Very good. It's excellent.
I'm entirely unbiased, but it's a great service up there. And it's actually, in theory, what happens between us and our partners in Hull in that particular city is meant to have each of those off-ramps, is that anywhere you're at in the criminal justice system, we know it doesn't work perfectly in practice, but we try to say wherever you come into contact with the criminal justice system, we offer that, how can we help you, you know, and it's tough to do because there are thousands of people going through that system. That's just in one city.
Churning through. One thing that's really interesting listening to you is although Mike, you said there's a challenge on continuity of care. In the U.S., it is a major problem for us because we have no funding stream that funds health insurance for people in the United States, right? Our insurance is based primarily on employed. If you're employed, you have some insurance from really crappy to really good. If you're unemployed, you generally have no health insurance. And the justice population in the U.S. is generally unemployed, right? Statistically, the majority unemployed. Some of them might get on a federal funding stream called Medicaid, which pays for minimal services, and mental health and substance use vary widely what that looks like. So we have huge continuity of care issues because we have no stable funding stream for an individual. And when you go into prison, the state has to provide, 50 states in the U.S., right, has to provide health care. But when you go into jails, the jail's responsible for it. So prisons look better, but the jails are responsible for it. But because health care is so expensive, including obviously treatment and mental health, many kind of do what they can and move you along to get you back out of the jail to the community where you have no treatment.
So if somebody's coming out or is appearing in court or coming out of prison in the US system and isn't on Medicaid, can they get access to substance misuse treatment, or is it just a non-starter? Yeah, you got to have money. There's no way to pay for it. So a local county that you live in or city might fund something, very limited, somebody said long periods of wait time. We have long periods of wait time generally. If you live in a state that has Medicaid, right, the federal healthcare program in the United States, which is for a limited slice of the population, it has to kick back in, which can take up to 30 days when you're released from prison. So we just don't have what you have, which is a National Health Service. Or our neighbors to the north, right, who you guys know well, Canada, they have a National Health Service also. But it is a major problem from the treatment standpoint
of continuity of care. And also for you, if you were a treatment provider in the United States, you would spend most of your time scrambling to figure out how to get paid, how to make money and keep your doors open and get paid, because there is no stable funding stream for it.
So this might be where the presentation gets competitive with
Yeah.
two sides of the Atlantic here, and I've noted.
Well, we're America, we're better, so I just want to, yeah. Okay.
Well, I've also
That's already, yeah, right.
noted
That's
your
settled,
reference to
yes.
rugby at this point.
That's right, exactly.
But we know, with all the figures I see, is that the US spends more on substance misuse treatment than European countries, but it spends all that money, but still a large chunk of the people you'd want to get treatment don't get near it.
Yeah, so in the justice population, so again, I say 7.2, let's just use 7 million, 60 to 80% of that have either diagnosed, or we can tell through behavior that they have a substance use disorder. There's, in the justice system in the United States, about 11% of the people get treatment, and most of it is mismatched treatment, right? Providing treatment in jails where populations are churning very fast. U.S. jail stays are under, I think it's under 6 days are the majority of stays. You can't like do treatment in 6 days. You can't do anything in 6 days, right? Make sure they don't like kill themselves, essentially what you do. And so you have this churn. So it's about 11% of the U.S. justice population will get access to treatment. And again, a lot of it is not really what you would, what anybody would say, okay, that's clinical evidence-based treatment. It's a group sitting in the corner of the prison, non-therapeutic, and they go to general population and all the things that go with it. And then it ends 2 years before they get out. Because as Mike and I will talk about, we have very long justice sentences in the United States. So you go in, you're going to be in for quite a while.
We're getting contributions from all around now. I think we go with that. Yeah.
Do we
so
need the
anybody
microphone
wants
over there? Yeah.
What's the difference between a prison and a jail?
So in the United...
It's confusing me, sorry.
Okay, yeah. Tell us the difference between a prison and a jail, because it's the same thing in the UK.
Yeah, no, very good. So because of how the U.S. developed as a nation with the kind of the frontier, right, the west of the United States, jails are developed or are able to be used by cities. So you can have a city jail, a county jail, which is the next government unit, and a state can even have its own jail. That's usually for short-term stays up to 1 year or right under 1 year, 364 days. You can be convicted and do it in a jail instead of going to prison, or you can just serve out your time there, not serve out, await your trial there. You could stay in a jail for 4, 5, 6 years awaiting trial. Jails are places of churn. They're dangerous places. They're rough places. They're not cool places to be. Of course, neither are prisons, but prisons are run by the state and federal government only and are stable. They're for people who've been sentenced 3 years, 5 years, 20 years, life, whatever it may be. And they're stable. They generally have more programming and cleaner, you have health care and all that stuff. But you're in prison now, obviously, and you're not getting out anytime soon. So jails are used by local governments to house people, store people, whatever it may be. I hate to use that word, but it's kind of what it looks like. They also are in the United States. Our largest mental health institutions in the United States are usually your local jail. So if you want to find your mental health population, statistically, just go to we have 3,200 counties in the United States. Just go to the jail and you will find a good chunk of the mental health population for that county sitting in jail. Because again, we have no National Health Service, so there's very little treatment to access for people. So they wander around in the streets, they get involved in stuff, they get arrested. Where I come from, Chicago, the county is Cook County, Los Angeles County, New York, Miami. Those jails house the majority, or they're the largest mental health institutions in the United States are usually your local jails, and then your prisons are next. So if you just look at raw data, you want to find them, that's where you want to go. You will not find other places from people who have mental health. If you do, they're small. They're in jail. They've been arrested multiple times, over and over and over.
On that question, which is about definition, because I learned something now, I was wondering what the difference was. Let's try our next slide. Plenty of time to come back in for everybody, because we thought definitions might be helpful here. We talked about one language. Even within the UK, which speaks English, which was the original language, we've got loads of terms for diversion. And I don't know if anybody in the room understands exactly how these different terms are used, what they refer to. So add that into the US terminology, and there's a bit of potential confusion there. So we thought we'd play a bit of definition chess here, and start with the generic terms, which this is mine and Jack's judgment, but there's the two blue ones up there are just generic terms for what we're talking about here. And we've already gone into criminal justice diversion is the collective noun for everything, all those off-ramps. Certainly from my perspective, we call that criminal justice diversion. Could be any stage of the process. You've been using this phrase in our preparations, Jack, called deflection. Tell us what deflection is.
And by the way, I'm moving, like I said, because that way I'm not blocking this, but the camera's here, so I have to come back. And while you did invent the language, we have perfected it, Mike. I just want you to know
improved it.
Yes, we've improved it, yes. Actually, I don't believe that, because I love coming to London because of the theater and the stage and all that stuff. So deflection, the blue term you see there, is a new emerging reality in the United States, and I give a lot of credit to the law enforcement because they really are the leaders on this, even though it's an interface to treatment. Deflection is the ability for law enforcement in the United States to have a third option, right? So in the United States, I can arrest you. If I find you doing something, I can arrest you. I can let you go. And it's called discretion. I just use my own decision on that, just like police officers do around the world. But with deflection, law enforcement is offered a third choice, and that is a connection right into treatment. For us in the U.S., that's new. That's a big, big deal. It's about 5 to 6 years old in a formal sense. We have 18,000 police departments in the United States, 800,000 police officers, and we have about 500 departments doing deflection right now. It's a rapidly growing area of law enforcement activity. It's a lot of interest in it, mostly because of the opioid epidemic, right? Police are the first responders. They get there. They go a second time or third time. They get tired of doing this. The chief says, what else can we do? Okay, we've got to connect people into treatment. But deflection is the term for this new emerging reality of law enforcement intersecting with behavioral health on those off-ramps, the same way courts and jails and prisons and probation and parole have been intersecting with behavioral health for a long time. Law enforcement in the U.S. has not generally done that. One minor exception I'll talk about is mental health. Mental health handoff from law enforcement, people who have serious mental illness, SMI, law enforcement handoff to mental health has been going on in the U.S. for quite a while. But it's not systemic, right? One department might do it, another one might not. Every police chief can do what he or she wants to do. Every sheriff who's elected, which comes from you guys, the Shire Reeve, right? Those are elected officials, they can do what they want. And so we have huge diversity of action. And some departments deal with mental health really as an officer safety issue. They want to stabilize the situation, put the person in custody, do whatever they're going to do with them. Others will stabilize the situation for SMI, serious mental illness, and then do the handoff to treatment. But otherwise than that, if you asked 5 years ago a law enforcement officer, so what are you going to do with someone who looks like they're using drugs? You say, well, I'm going to arrest them or I'm going to let them go. Even now, obviously, with so few departments doing it, but there are no movements within the police ranks and certainly within police chiefs who are taking a strong leadership role and saying, we've got to do something more. And I'm going to finish with this, Mike. It goes back to my opening comments. Why? Because 40 years of research has told us in the United States, even though we have ignored it over and over and over, that treatment works. For the right person at the right time and the right place, treatment works, and we know that. We just have to kind of get that into our thinking in America, and what the police chiefs are doing will yield more and more results and will expand. So that's deflection.
So early diversion, those reds there, arrest, referral. Does anybody remember the phrase arrest, referral? Show our age. But law enforcement diversion, pre-trial diversion, those things have been around for a long time. You're saying that they're catching on in the US.
Yep.
Yes, the evidence base, I expect most people in the room would agree, the evidence base is it's much more effective to get people through behavior change programs, treatment programs, than put them into criminal justice processes. That evidence has been there for a long time. Why is it only catching on in the US at the moment to say this is a good thing to do?
Yeah, because people are dying. The opioid epidemic is driving in the United States change for behavioral health, all you behavioral health folks. It's driving change for you and it's driving change for law enforcement. So we topped out at 67,000 people overdosed and died last year in the US. Our curve is still going up. I don't know what number we will hit in 2016 was 67,000. The numbers aren't fully in for 17. It's going to be a little higher than that. The projections will go as high as, depending on what modeling is used, 100 to 150,000 people will die a year from overdose. As this continues to move, we're nowhere near out of it. So the opioid epidemic is the main driver of the movement of law enforcement saying we have to do something different, we have to connect to treatment. In part because they're going out to revive people over and over, multiple times with naloxone, Narcan, FZO, whatever it is that they're using, and then they keep going back over and over. And so just from a practical standpoint of resource allocation, hey, we got to do something different. But it really is the opioid epidemic. Police-community relations are a part of it. I won't go into that. That's a different presentation. Mental health is another part of it. And then in the U.S., and again, that's a different presentation too. But in the U.S., remember, we have no national health service. Our public health systems are very weak in the United States. If you are not employed, you're out of luck, right? You're out of luck on terms of health insurance. So we have asked our police in the United States over the decades to do more and more of the social service stuff because there is nothing else there. And so we asked them to deal with truancy, we asked them to deal with people who have mental health issues, we asked them to deal with people who are homeless, and we call them to respond to those calls and ask them to do. Well, what do? They can arrest you or let you go, right? And that's kind of how the U.S. Has developed, unfortunately.
So those figures, I mean, I'm sure you'll agree, are astounding figures, 67,000 people dying. You know,
that's just deaths, that's not overdose,
Yeah.
that's the actual people that actually died, yeah.
And I've given many times in speech the European equivalent of that, and the UK equivalent is we have 3,000 drug-related deaths a year, which to me is an absolutely shocking figure. It's more than dying car accidents, more than dying accidents generally. And that doesn't seem to move our policies or our politics at all. That death rate was half that level 20 years ago, and we were very energetic in trying to invest in treatment and harm reduction and services to respond to that death rate. Death rate has since doubled, and we seem to take it less seriously than we did 20 years ago. Now the US has a different history, and so with those shocking statistics, you think there's a real political drive now. That's real rather than a few good speeches and then everybody goes home?
It's real. It has a political impact at this point. And there's lots of reasons, some of which are speculative. And I don't want to avoid in this conversation not bringing up the issue of race, so we'll talk about that a little bit more, race in the United States. So if you're black in America, if you're poor in America, that intersect with criminal justice is very high, right? The percentages are very high. What we call disproportionate, I'm white, I'm gonna let you in a secret, I'm white, right? My interaction with criminal justice just by virtue of being white will be less than someone who's black, my neighbor who's black, for example. So in the US, we'll talk about that a little bit, but we have to put that in play. The reason I bring that up now, Mike, is in response to your question about the opioid epidemic. When we call it an epidemic, it is. I mean, the numbers are very, very high, as you heard me quote the stat. By the way, in the US, you hear a lot about gun violence. Gun violence deaths in the US are about 35,000 people killed a year. Many, many more shot, but about 35,000 people killed a year. But the opioid epidemic is at 67,000, right, in 2016. So just to kind of put it in perspective, if you're afraid of coming to the US, don't worry too much about being shot, worry about using drugs. No, just kidding. But anyway, the political equation is there now for that, and so the United States just passed, under President Trump, a $2.2 billion package for the states to deal with opioids, coming off a $1 billion package last year and another $4.4 billion coming in the next few years. We've never had so much money going into a single stream before in the United States in the public health arena. I mean, that's huge amounts of money. It's so much money we won't be able to spend it all, by the way, because that's tons of money. And again, remember, we do not have National Health Service. I know I keep going back to that, because really what that money is, it's in place for things that otherwise healthcare would normally just pick up, right? It's money for treatment, it's money for prevention, it's money for recovery, it's money for naloxone to reverse overdoses. It's money for all the things that for you, probably in your world, says, well, these are just things that are paid through a health service or the corrections budget, but for us in the U.S., it doesn't exist, so therefore it's appropriated or funded separately by the government.
Just a little tangent on naloxone. It's present here, it's present in most countries. Yeah. The early studies have indicated that it can be effective, reducing overdose rates, reducing death rates. it's been taken on in the US very quickly.
Yes,
From a
very
very low
much.
base very quickly.
Yep.
I'm sure that's related to the figures you're talking about. In the UK, there still seems to be a fair amount of ambivalence, and I can't work out whether that's people are waiting for more research, or the funding systems aren't there, or there's technical problems with it. People who work in the UK treatment system, are you seeing naloxone being comprehensively provided or marginally?
So I've got a treatment population of 1,200 a year, and I get £2,000 a year for naloxone.
To buy naloxone?
Yeah, so you have to be quite strategic about who you give it to, and it's
Right.
usually people, there's usually people coming out of prison, people who are coming out of custody and rehab and injecting users. It's very hard for us to give it universally to everyone, so we don't have the money.
So that's a financial
But
barrier
it is a
there.
financial-
There's no
yes.
political trying to stop it happening. It's
Oh,
just
God,
nobody
no,
gives the
no.
resources.
I just
to it.
don't have enough money. However, another service is ours in Brighton. They get loads of money. It's kind of postcode lottery really with the commissioners.
Yeah.
Can't you through the National Health Service though just go and, well, that's interesting, because in the US, if you have insurance or you have Medicaid, which is the health insurance program for the poor, it will often be covered. Once you get on it, you can, now you might have to pay a fee, but it's not the cost. Naloxone is not expensive, but it, you know,
No,
you
it
don't
comes
have money,
out,
it costs.
Yeah, it comes out of your core budget through the local authorities.
Oh, that's interesting, yeah.
Any other experiences in naloxone? There's a couple at the back there. Sorry, Ron. Should have got two microphones.
And if you have experience with it, would you throw into your comments, if you have experience with it, how much you think you could have, you should have, right? In other words, you have people overdosing who could have used naloxone, or their families could have.
I work in a prison, and I deliver naloxone training, and with the clients that I actually work with, it's very welcomed actually for them to take home on release.
Yes, absolutely.
I think it's really important that obviously, you know, we do supply this for our clients. We work very well with IDTS, who make sure it's actually given to them on release. It goes in their prop box. But I honestly, I think it's an asset. We really need it.
And it is available when you need it.
It is available to them, and obviously, you know, if they don't want naloxone on release, we make sure that they actually sign a disclaimer to say they don't want it. But you know, with guys that I work with, many of them really welcome it, and they welcome his training around it.
Well, that was what I was hoping to hear, because I think there's no policy problem in the UK, but it's not a drive as I see in America. So this must be available everywhere very quickly.
But it's really interesting when you do the training with them to know, to see what their knowledge is around it. You know, a lot of people that I work with have very little knowledge of naloxone. They've heard of it, but they don't really actually have the training around it. So doing the training with them, you know, seeing what their knowledge is really interesting for me as a practitioner as well to see this. But it's also good for them to be taken home, and also not just for themselves, but obviously making other people aware of it that are using opioids. But obviously we work very closely with IDTS, and I say it's given to them on release, and it's all signed for.
That's good.
No, it's a good tool we've got.
Do you give it to the family? So you give it to the individual?
We
Do you give it to the family also?
The client, no, it's purely for the client, and the client does the training, you know, and obviously the people around him, I'm hoping that he obviously educates other people around the fact that he's also got it, and he's actually sort of in possession of it.
Yeah.
But it's really working very well. In the prison that I work with, the training itself is going extremely well.
Great. So, gentleman behind you, I think, and two at the back there, yeah.
I'm one of the secretaries with CGL. It's something that has been pushed year in, year out. Any patient from any CGL patient, and even any patient who is an opioid misuse patient, he has to have an naloxone. And it goes through a computer system, in which case the expiry date is there. So when you see them again, you are always reviewing it. And if you have a feeling that, or from the notes, you find that the medication is expired, you make sure that the patient walks out with one. No patients go out without any. Yeah.
And in your projects, do you have the same problem as our colleague over here, that there's a limited budget, limited stock?
No, not at all. It is mandatory. we don't have that with. We have that sort of problem.
Because although we've got an NHS, Jack, is that the NHS has a budget system.
Sure.
And if somebody in the system says,
Right.
this is the limits to your budget, and we generally have reducing budgets, then there may be perfectly good policy system treatment, but you can only spend the budget you have
That's right.
available, so you
Yeah.
have to make some tough choices with
And
it.
naloxone's through the public health budget, for treatment too. It's not
Yeah,
actually
it comes
through
out of a
the
different
NHS, so
budget.
It's
Yeah.
different. It's
Yeah.
confusing.
Just to add to the few comments we've had here, at the end of the day, naloxone costs £18, so a kit costs 18 quid.
That's about right.
That can save a life.
That's
okay?
right.
The cost of a death, if you take aside all the other stuff, the
Yeah,
emotional
yeah.
stuff to the family, the damage and everything else, just how much that costs to the NHS, there is a cost attached to that.
Yes.
What I find appalling to hear, and I have to take that off to the organisation over here, there is one organisation, CGL, that we know, it doesn't matter whether it's in the tender or not, they will pay for it, and they will give those kits out, and they will throw them out. It's sad to hear other agencies,
Right.
both criminal justice, both prison and community, saying, sorry, we don't have the money.
Right.
When you think what you're going to, we've
Yeah.
now had record deaths this year. We're on a trajectory. Our deaths are going up year on year in this country, as they are in Scotland as well, and yet we still have people saying we can't afford to give these kits out.
Yeah.
18 quid compared to a life.
Yeah, it's nothing.
Appalling.
Yeah. Yeah, it's the same in the U.S. The cost of dying is much more expensive than the cost of living. Yeah, good.
Yeah, the service in Hull delivers training for the clients, and the clients can then take the naloxone. There's the naloxone kits around the community hubs, you know, which are provided by, you know, the service that we join partnership with in Hull CGL. So in Hull at the moment, the naloxone is readily available because we work alongside CGL, you know, and you know, it's widespread across Hull. The peers know about it, the service users know about it, the staff know about it, the community hubs know about it, you know, the police on the streets know about it. So yeah, it's kind of widespread in Hull, which is really good at the moment.
Yeah. So naloxone's great, but of course the whole trick is to do the connection to treatment, right? Rapid connection to treatment. They won't talk to you right after you revive them from overdose because they're pissed off. And
They'll sign a
vomiting
form.
and all that stuff. But yeah, that is the whole trick. So we have some municipalities in the United States where the overdose death curve is starting to flatten out because of naloxone, but the connections to treatment are still very weak. And so we know that won't hold, right? The naloxone stops the death but doesn't connect you to treatment. And that's why going back to deflection is so important. So and I know we got to keep moving along.
That's important to remember the context of this, and this next slide is about the different contexts of US and UK systems. One different context is there's an overdose death epidemic in the US, and that is driving activity, not always a solution activity, right up to the level of the president. The president gives speeches about this. I'm not going to say anything else about the president. In the UK, we have an overdose death. Probably hard to call it an epidemic, but it's at a level which is really society level. Nothing's happening in government. Absolutely nothing. There's nobody in our government saying, I'm going to deal with this, I'm going to make this a priority. So I'm not surprised to hear some of the things about budget priority there.
I'm just wondering, what is the causes of this epidemic in the US and the rise in the UK? Because
well, I was trying to think about that. I was going to ask the audience, but I'll give my take on it because we peaked in our political interest around substance abuse treatment 20 years ago. So we put a lot of extra money into substance abuse treatment 20 years ago, and we did some things great, we did some things less spectacularly. From a political point of view in the UK, the politicians think this is a problem that's contained. Yep. So I went into government in '97 at a time where there was a general feeling of this drug problem in the society, we've got to do something to get on top of it. What you've had, and I say you had a lot of money spent around the millennium and into the first years of this century. What you've had then, the political judgment that's made by people who aren't interested in the welfare of drug users at all. The judgments they're making is we've managed to bring crime down, our HIV rates are under control, we don't have any of these big headline problems, so we don't have to prioritise the issue. And that's been the case for some time now in the UK, and it's distressing. What I've never understood, and that's why I was asking people's perspective on it, is why 3,000 deaths a year doesn't change that. You know, that's not okay. Yeah. But as I say, there is nobody in politics, which is useful that we found out there's no politicians in here. But there's nobody in British politics at the moment who is saying we need to have a big drive to get this right, or spend more money on it, or reduce the overdose death rate. It's quite shocking. So there's a lady in the
Just something, isn't it in the States that it's mostly white people that are dying? I heard
From
someone say
opioids?
this morning that
Yeah,
some
so
people, exactly white people,
Yep,
as
that's
opposed to
correct.
black, and President Trump and eminent white people's children are dying, so
Yeah.
that's why it's become important.
Yeah.
In this country, if you like politicians' children, maybe these days, if they get a problem, they can afford to go to private treatment. And so do the people who can't afford treatment, this is about neglected, not thought about.
Yeah.
So that for
Yes.
me is a sort of an economic or class and racial.
Yeah, there's definitely a race element to the response of the United States now to the opioid epidemic. Opioids, heroin in the U.S. is just called dope. It's been called dope on the street for a long time, back to the 70s. There's nothing new about it. So in 2015, 33,000 of the overdose deaths by the Kaiser Family Foundation did some research on 33,000 out of, I think it was 42,000 then. So the curve is really going up. We're white. And so some people speculate, and I think it's kind of a fair assumption that because of who's dying now, that more attention is being given to it. I do want to say though, the number, and that's why I gave you the deaths by guns, the numbers are still off the charts. I mean, let me be very clear on that. And they're mostly in rural, poor areas. And I can, to get to that question, I can answer why that is. So there's an element of race here because race is infused in a lot of what we do in America, whether we acknowledge it or not, and the disproportionality of how poor people and how blacks are treated, black, brown, people of color, is absolutely there. There's no argument about it. So yeah, I want to acknowledge that, but also just say, there are lots and lots of people dying. I mean, more than guns, right? And that's what America is known for, is guns, right? So opioid epidemic real quick. 4 out of 5 people who now have an opioid addiction in the United States come from pills, prescribed pills in the United States. And that is basically the origins of this heroin epidemic, this opioid epidemic, traces back almost entirely to medications, either prescribed, obviously overprescribed. You go into the doctor 5 years ago, he or she would give you 100 pills, like 100 oxycodone. It's like, what is that? And then you take it, maybe you get addicted, sits in your shelf, the kid takes it. I mean, those stories are rampant. So, but the research is 4 out of 5, 80% that are now having OUD and opioid use disorder have in their recent past a legally prescribed opioid for painkillers.
Before we move on, I don't want to lose the class analysis, because certainly in the UK setting, 3,000 people dying, 50,000 people going to prison each year because they are unwell would be a scandal. If that was something that was close enough to home to the people who turn up to make the decisions, then something would be happening. So I think there's an unease I have about all this, because behind all these statistics are people, we work with it every day, and it should be important. And it was important for a while, policy-wise, but I really started to do a lot of work up in Westminster trying to get opposition politicians, government representatives really interested in, this is what we need to do, this is how we do it. Because the field, and I'm sure it's the same in the US, we know how to solve these problems.
Yeah,
we know what to do.
We know what to do.
With the right backing, with the right support, with the right institutional structures, you can make a lot of difference to a lot of people's lives. But I think the class analysis is part of that, sadly.
Did you have a question?
No, I'm just enjoying what you're saying. Yeah.
Okay. What he's saying or what I'm saying? Oh, good. Okay, yeah.
Just equally.
That's right.
Yeah,
so equal. Yeah.
Which flag do you prefer?
That's right. Exactly. Yeah.
I'm not getting into that.
We've gone all the way off piece. This isn't a lot of this stuff is not what we aim to do, but that's great. That's what we do. And actually, quite a bit of we got a few more slides drawing out some of the issues around this, but and two really important points. Yeah. But this was what meant to be kind of give a sort of historical perspective how the systems have developed each side of the Atlantic. I think we'll go through this very quick, Jack. But of course, a lot of these questions have come up already. But do you want to tell us a little bit about how the U.S. system got to be what it is today?
Yeah, so America, how many of you have visited America? United States, okay? We are a law and order country, and if you see law and order when you get there, kind of that attitude. We are law and order, right? Wild, wild west. That's kind of, you know, in our DNA, in our blood or whatever. And so this idea of law and order permeates our culture, and that is why we are where we are for the most part, right? Protestant point of view, right, wrong, black and white. I don't mean racial color, but how we look at the world. Not a lot of things are gray in for us as Americans. And so, unfortunately, that means you have to bifurcate solutions into up or down, left or right. And so it's very easy to get to this point, which is described on the left-hand side here. I will give you two, since we have a lot of treatment folks in here, use of treatment actually, though, in the criminal justice system in the U.S. goes back long, long way, right? Probation goes back to the 1850s when it's developed. But the use of treatment actually is a long-standing. It's just not funded, right? It's just not funded. So we acknowledge, and this is what this second chance, where it says there's second chance philosophy. We also have this other stream within American thinking that everybody deserves a second chance. But we're not quite clear on exactly what that means or who it's for and who should get it. So while we have a tough law and order, we like to think of ourselves as people who are willing to give others a second chance. And so we have kind of sometimes some very minimal efforts to try to get at that. But mostly the U.S. is a law and order criminal justice system. It's pretty tough, it's pretty harsh. If you are black or you are poor, you're in trouble if you touch the criminal justice system. You're going to have disproportionate outcomes on arrest, on conviction, on sentencing for the exact same thing as I would, for example. And we know that statistically. And I want to also say that lots of people are working on this in the United States. Many states are doing a very good job on turning the corner on some of this stuff, but our history is very, very clear as it comes to race and law and order and get tough. And so for us in the U.S., someone doing 7-8 years on something that here may not even go to, you know, go to prison is not unusual. So you go in and you go in for like long periods of time. You go in and you know what happens in prison. You become acclimated to that environment. And you would and I would, and we'd come out messed up. Why? Because we wanted to survive, and so you do what you do to survive. But it's very different than what you guys have in the UK.
And that's the main distinction I wanted to make in this slide, is that we do start from a different place in terms of the harshness of the criminal justice system. In European terms, the UK system, in terms of rates of imprisonment, in terms of length of prison sentences, is towards one of the harsher of European systems. But we don't compare to the US, or we could say Russia as well, so those sort of high prison populations. Particularly in terms of drug law offences. I think probably it's generally understood, but just to emphasise it, coming in the UK, there's a tradition of almost like instinctive diversion for drug law offences. Possession of drugs, consumption of drugs. Generally, you would not end up with prison time in the UK for those offences. There are actually, in our current figures, or our latest figures, which are a year or two old, there are 800 individuals who went to prison for, or had a prison sentence for a drug consumption offence. Now, if you're one of those 800 of the 5 million people who've used drugs in any given year in the UK, you've been very unlucky. But I've got to say, most of those 800 will be concurrent sentences with other offences. So generally, you don't get prison time for drug consumption offences in the UK. What I'm sure you do see a lot of in our prisons and in our courts is people charged or arrested for drug-related offences. So it might be what I call fundraising offences, which is raising money to buy drugs, or under the influence offences, or offences related to drug market. So we do have a high proportion of our prisoners, same as you do, high proportion of the people in court are involved in drugs in some way. But generally, if you are a recreational drug user who has no other offending, no other presented problems, then you're not going to go into the harsher ends of the criminal justice system. And that's very big numbers, very big differences in numbers. You talked about the 7 million, large number of those under drug offences. We don't have that many people in our prisons there for drug offences. Yeah. What we do have is a large correlation between certain patterns of drug use, dependent patterns of drug use, chaotic patterns, and certain types of crime. So retail theft and burglary, robbery. they're very associated with what used to be in my day, and we got used to in the 80s and 90s, say, you could pretty much say if somebody was a daily heroin or cocaine user, then they would have a correlation with this offending cohort. And if you were a cannabis or party drug user, then you weren't. And we actually based policy on that. We said, okay, we want treatment response to people who are daily heroin and crack users, and we wanted a diversion response, deflection response to people who had less problematic forms of use. Now the main thing I want to say in the UK, and I don't know if other people are feeling it as well, but certainly across the 30 years I've been involved, is I just have a sense of drift in policy at the moment. 10 years ago, 15 years ago, we had a drive that we wanted to identify those people who needed treatment. We wanted to get them into treatment through the criminal justice processes, and we spent a lot of money to do that. What's happened since then feels to me like drift. Is we still do those things. We still, as you heard from the projects we're all represented, we still try to do those things, but there is not the financial and policy drive to say this is a really important piece of work to do. So around the country, and our system is divided up into 150 different systems. So we got local authority boundaries, and they each run their own treatment system. But so you can't really categorize that it's the same everywhere, but generally it just feels like all of those good ideas are not having the financial and political backing they've had previously. And some areas are finding, as we've heard, some areas are finding great ways to spend less money but achieve great outcomes, and other areas it's just drift. The money's slipping away, the projects are being closed, and the services are degenerating. Now that's my feeling. Maybe I've got a sort of a rose-tinted view of how it used to be, but I do think we're in a stage of drift in the UK, which can only increase the problems.
Yeah, can I just answer? I work in a drug treatment community centre that used to be CGL in North London, Islington. Now, we used to operate the drug treatment service, the DIP team, and the NHS prescribing services. Now, we've had to have the contract re-tendered because every 2 years that happens in most boroughs. Now, what's happened is because of cuts and reduction in the money that's available for treatment, now they want us no longer working in so-called silos. They want the borough to be working in partnership together. So if I'm the peer mentor lead, the volunteer lead, counsellor, I'm going to network with all the other counsellors in the other services that used to be the silos. So you've got the NHS, you've got WDP or CGL, SHP, all working together under one umbrella. Now there's a lot of teething problems with that because we have to get used to each other's system, but we're on the same page, we've got the same heart, we've got the same sense of ambition for, people in recovery. So that's what's, it's not drifted, it's changed. But we're still beholden to the powers that be, the commissioning team, the boroughs, councillors, what they want, and they're not always listening to the frontline workers and staff that really go out and do all the outreach, do the arrest referrals, go to the police stations. They're not really grasping what's involved.
Well, what you've described there is the costs and the benefits of change. So the benefits are, let's look at it, let's see how we can do it more efficiently, how we can join it up better, and good professionals will find ways of doing that. The costs are you're constantly reinventing stuff, and constantly reorganising it, and a new boss and a new organisation and all that sort of thing. Just a question, in America, do you have this as well? So say you've got a treatment system in Chicago. Do you reorganise it and retender it and recommission it every few years? So different people bid to run it?
So when services are contracted, just like you were talking about, to tender it and retender it, we run through the same process if it's government funded. So it looks identical. That's just contracting. Right?
Every so often? How often?
It depends on the government.
The slight downside to that is it has a direct impact on people who change. They're just about grasping their cycle of change in terms of moving through the chaos and into...
The cycle is unrelated to
and you're just
anything
upsetting
for
that for them.
Exactly.
By changing provider,
Exactly. Yep.
tendering. It's just like, who's my key worker?
Yeah.
Where do I go for this? Am
Right,
I going to get
right.
counselling? And it creates havoc for them.
For the individual
Yeah.
seeking treatment
Might be
or
all
in
right for
treatment,
the commissioning
absolutely,
team,
yeah,
but
absolutely.
It's real havoc for the client.
Yep, absolutely, yep.
I just wanted to highlight that.
The contracting process is
When you talk about
detached
drift.
from the need for service provision. It's an administrative process, about every 3 years, 5 years, which has no relationship to the provision of service. It's about the contract. It's
Yeah.
not tied into good outcomes, evidence-based data of when the contract might be, just an arbitrary number of years in which it's done.
Sorry, it's just back to the criminal justice money.
Yeah.
It has, I think it was being decommissioned effectively, especially in London, because the money, after it went away from the Home Office, went down to the MOPAC, which is a mayor funding. Some boroughs aren't even getting anything now because it went to local authorities and then they could spend that wherever they wanted. And I know in my borough, most of the drug intervention program money went to domestic violence.
Yeah.
And there's a cut on year until I think next 2 years.
Yeah.
They're expecting services to actually absorb that and go on as business as usual. However, if you're running clinical services, clinical risk supersedes the rest of the stuff, and we're now getting to the stage where we're tipping over and we're just going to end up running clinical services without the other stuff. And I don't agree with it.
Yeah.
But that's where the criminal justice money's going.
But that's what I mean by drift, is 20 years ago, 15 years ago, we could say we want these off-ramps, and we had an actual funding scheme for each off-ramp. We had a police and arrest referral funding scheme. We had what was called DIP, which became a police and court integrated off-ramp system, and we had the prison and prison release investment. What's happened, all of that money's gone into general pots, and some organisations keep investing it, and some just forget it or try something different. Question to the audience: in the UK, we get told that what's going to solve all the front end of this, the police station, prosecution levels, is liaison and diversion schemes. Anybody seeing those being implemented in their area and getting the grip with this? That's the new model that's meant to work this out. Anybody heard of it? Well, that's not too resounding a success, because that is the new fashion. And it does, there's some good ideas behind liaison and diversion, which I think you were referring to, is saying, well, let's not have a drug and alcohol police station scheme and a mental health police station scheme and a homelessness police station scheme. A lot of these guys are the same guys. Let's have an integrated thing, and the money will go further. So it's got some sense to it, but it is the latest, as I say, version of let's really get this pushed along, and I don't know how widespread it's getting, and it sounds from this audience probably not a representative sample, but we're not seeing a lot of change as a result of that. But that's what's coming, liaison and diversion schemes.
Yeah, Mike, I was just interested to hear what you were talking about in terms of a drift, and I think from where I'm sitting, that drift has been, in very simple terms, exemplified by the reduction in availability of residential treatment, and that's incredibly significant. I mean, we know at Steps to Recovery, and we're not touting for business because we don't charge. Nobody pays for treatment at Steps to Recovery, but we know for a fact that if people complete treatment at Steps to Recovery, 50% of them, 6 months later, are still clean and abstinent. So residential treatment, if approached in the correct way, can work and does work. And that drift away from residential treatment has been massively damaging, I think, to the situation as it stands.
Yeah, and part of the drift is what sort of treatment people go to, and it's very tempting for a budget holder who's trying to save money to say, I'll send people just to the cheapest possible service, and the cheapest possible service is have a little chat with somebody and hope that your life's transformed. That'd be a great counsellor if you could achieve that. Shall we click straight forward? Because I'm looking at 3:15.
The last slide.
Should we go? Yeah, should we go to the
diversion?
What you're on it?
Well, I went to the last slide just for that.
Because basically, when me and Jack talk about this, once again, US and UK have very different experiences of what do you divert people into. So if you have a good scheme, whether it's pre-trial, whether it's a court-based scheme, or whether it's a post-prison scheme, it really matters what sort of treatment you send people to. And part of the drift I've been seeing in recent years in the UK is the idea that everything's treatment. as long as you got somebody to fill in a form and attend
Yeah,
an appointment, that's treatment. No, it's not. Treatment is what's going to help people turn their lives around. Now, we can debate about what model is going to achieve that best, but it's got to be something that has an impact. It's not just fill a form in and have a chat. What's the U.S. experience?
So that is different in the U.S. So while we don't have our social service safety net in the United States has been de-invested now for decades. It is a massive problem for us right now. If you are poor in the U.S., your likelihood of escaping that is very, very small at this point. We have about 37 million Americans classified as in poverty. The social service system is virtually non-existent. Demand versus need, right, in the U.S. Kind of we're on our own. It's that whole idea of we're on our own, pull yourself up by your bootstraps. However, on the treatment side, what's happening is evidence-based and data-driven is the norm. In fact, right now, if you want to go for federal funding or foundation funding, so the federal government or foundations to fund you, you're not using evidence-based practices, and you do not have data and evaluators, PhD evaluators. I wanted to ask you guys who said, oh, my program works, if you were here in the U.S., I would ask you and you would right away know your numbers because you are so afraid, I don't mean afraid, you're afraid of, and so would the police chiefs. They would know their arrest numbers, their success rates, stuff like that. So in the U.S., we are big on technology. We love our technology, and so data and evaluation are huge for treatment right now. The problem that's causing for the treatment field is the abstinence folks only are in major retreat right now because abstinence only has no good research behind it, right? It is a failed model. And the U.S. has been pushing back on that for a long time. And oddly, because of the opioid epidemic and medication-assisted treatment, which has research behind it, the abstinence-only folks are withering underneath the pressure of that, which is very good. Right, it's very, very good. And then the other thing, as I said, is evaluation. If you're going to get money now, you need an evaluator to show that it's working. Yes?
Sorry, when you say the abstinence-based model is in retreat and it doesn't have any research, are you talking about the 12-step research on the 12-step fellowships, or are you talking about research on abstinence-based, for example, residential treatment?
Yep.
What are you saying?
Yeah. So the 12-step model is not what I'm talking about. I'm talking about treatment that promotes abstinence and abstinence only as the path. In fact, in the criminal justice system, if you're a drug court, a court that handles that, you cannot even be certified if you are abstinence only anymore. You cannot be certified because it's considered, it's like junk science.
This is another difference between the histories. Up until recently, the whole drug court system particularly could only refer people into a program that was considered abstinence only. That was the only pathway. Now, we can debate about how effective that might be or otherwise, but it was not a menu of options for anybody. You went to this program and the numbers weren't great. The history of the UK system is more of a variety of options. So if you had your treatment system in any given county or borough, you'd have all of the treatment options available there in theory to people being referred from court for prison. But in practice, the vast majority was the other way around. The vast majority of people who were court referred to treatment would be referred to medication treatment. So our history and our background is, I think as you're referring to, is the large numbers would go into medication treatment and the abstinence-based options were there, and there is experience, but they were the smaller numbers and found it harder to get funding. In terms of the effectiveness of the programs, it's very interesting. If you did the analysis of the effectiveness of 12-step treatment or other abstinence-based models against substitution treatment or mixed models, there are evidence bases for all of those models if well delivered and well sequenced. But the drug court figures, I think is the ones you're referring to, is saying that everybody was piled up in short abstinence-based programs, so it was quite crucial there. The criminal justice thing was 6-week programs. The figures didn't come out that well. So the US is diversifying from what it used to have. We're probably narrowing in.
I don't want to keep banging on about what we do, but basically we work with people who are leaving prison who are motivated to work on their recovery. They're not people who've been sent to treatment by the courts. They're not on DRRs or whatever else. They've said to their forward trust worker, people from Mike's organisation, that they really want to get clean They want to work on their recovery, and that's when they come to us. And that's, you know, that's an important distinction to make, because otherwise we're sort of comparing apples with pears, oranges and whatever.
Yeah. So it's interesting. In the U.S. we use the coercion data, and the coercion data in the U.S. for the substance use disorder population shows almost identical outcomes to those who are non-coerced in the justice system. So we are good with coercing you to do something because we want you to get better. We're not bothered by that.
One of the slides we skipped that I find fascinating about the US and European comparison is the stakes are so much higher in the US.
Yes.
If you're in the even in the early stages, Jack mentioned it earlier, early stages of criminal justice system there, you're in the lockup, you're having a bail hearing or something. If things go badly for you, you can end up in prison for a lot of years, even if you're relatively minor offences. So the stakes are really high. So the decisions you'll make about shall I opt for treatment or shall I plea bargain or whatever, you make it. There's some really high stakes hanging on those decisions. In the UK and Europe, the stakes are probably a little narrower. Your options are wider, and you're unlikely to end up with long prison time. So a lot of the decisions that defendants will make may be motivated by different things, hopefully by the commitment to recovery, but not always. But I would agree with our experience has been the same as Jackson in the US, is where people are mandated into treatment or nudged into treatment or encouraged into treatment because they'll get a good court report or they'll have a better hearing at their bail hearing, the results are as good as people who've turned up voluntarily.
The harm reduction
statistically,
folks don't like it. You know harm reduction. The harm reduction folks in the U.S. don't like it, but that's not, harm reduction is not big in the U.S. Needle exchanges, safe injection sites, that's very, very small in the U.S. On the justice side, there's public health for HIV/AIDS, obviously that exists, so that's there. Mike, we're down to 3 minutes, so just want to make sure we end with them with any final questions, thoughts. This really was meant to be exactly what it was. You guys did a great job. It was meant to be just a wide-ranging conversation, not to instruct you on criminal justice systems in the U.S. or U.K.
And your evaluation forms give
job.
Yourself 10 out of 10.
Yeah. Good. But any final questions or thoughts?
Is methadone not used in prisons in America?
Methadone is used. We have 3 medications in the U.S. that we use for opioid disorder. So we have Suboxone, methadone, and then Vivitrol. The problem we have in the U.S. with the medications is, expense aside, is that Vivitrol, right, which was proven under the Russian studies, like the justice system loves it because there's no opioids in it, right? It's a complete blocker. It's not like naloxone. So the justice system generally prefers Vivitrol where it exists, but from a medical standpoint, judges and probation police cannot prescribe medication. It's malpractice. They have no law, no medical license. So that's our thing. But we do have methadone. Methadone is highly stigmatized in the United States. It's associated with criminal activity. And so if you go to a methadone clinic, like back in the day, you go there, you're going to go there because you're trying to find someone who committed a crime, and they're in the methadone line. So it's highly stigmatized like drug addiction itself, where Suboxone and Vivitrol do not have that stigmatization with it. Does that help? Does that answer?
And just quickly, AA used to be very, very big in America.
What was?
AA.
Yeah.
It came from America.
Oh, it's huge, yeah.
Has that now gone? Because that was abstinence-based.
So AA is not treatment. AA is not treatment,
Oh,
right?
right,
So,
right.
yeah, AA is not treatment. It's a recovery support element. We do
Right.
not consider that treatment. You cannot get funded for it. You cannot consider it treatment. It's just support. It's recovery
Mutual
support.
aid.
And the research we have on AA says if someone is already in recovery, AA helps them stay out of recovery. If they're using, it will not help them get into recovery.
And drug courts will not refer to AA.
It's not treatment. It will be a support element. Probation may say, okay, you have to go to AA, but you have to do treatment. You must clinically hit the milestones. AA is recovery, so it's not considered
But
treatment.
it's important to say that
That's very helpful.
the residential programs, particularly the short residential programs that have been dominant in the US for decades, are all based on principles of AA and NA. So there's a lot of 12-step movement over there. But the history of that dominance has been drifting, I think. So a lot of the treatment system that used to be structured fellowship-based treatment systems has become very diffuse now. A lot of private sector organisations, a lot of low-quality programs, you know, so it's not as simple as it used to be.
And smart recovery, that came from America. Is that not big China?
So is smart recovery, is that like an evidence? Because we attach the word smart to like smart probation, smart prosecution.
It's a non-12-step mutual aid.
Oh, okay. I just don't know what it is.
It came from America.
Yeah. Well, it must be good then, right? Yeah. I will just say this, for behavioral health in the United States right now, is especially private funded, or I should say public funded, is in complete turmoil right now. It is going through a massive change, again, because of the need to show evidence of outcomes, the need to accept that abstinence only its day is come and gone. No one buys it anymore. You have to do medications, you have to be clinically licensed. It is in turmoil right now. So if you're a good business person, come to the U.S. and you can find a
disruption opportunities.
Yeah, disruption opportunities. It is struggling big time right now. Yeah.
I know, sorry, you might have answered this. I was out of the room for a while. So say you've got someone that's got no work history, unemployed, homeless, drug addict, wants help, wants to go to the services, no national. Can they access treatment without insurance or any funds?
No, there's no. We'll arrest them and put them in jail.
Statutory
we'll arrest them and put them in jail to get treatment.
There's no universal access.
So we can go to CGL, Turning Point. There's a lot of, each borough has a drug and alcohol substance, community based.
Oh, I know.
They can walk in,
yeah,
get assessed. All right, they might get funding, they might not, but they would have one-to-one. And so is there nothing like that if you've got no money?
Yeah. So it's funny, I'm holding the bottle. I want the TV to say this says water, by the way, because I just realized there's been this whole bottle sitting the whole time, and probably that looks like vodka or something like that.
That's been Jack's support for this, yeah.
It says water. So in the U.S., every county has a public health entity, so like you can go there and get a free flu shot or something like that, and they have treatment. So yes, you might wait 6 to 8 months for your appointment. I'm not making that up. So the answer is no. There's no effective treatment because you can't access it rapidly.
I would have thought the majority of those clients are going to be the ones that are committing crime, revolving door, in and out, being shoplifting, antisocial behaviour, in and out of county jails.
Yeah. Well, if you got justice involvement in the U.S. though, and you go to your local public health department, like a pregnant woman will be prioritized higher, which is fine. Like I have no problem with that. So they're not. There is no. You guys have to hear that there is no stable social service net in the United States.
It's insane.
There is none.
So you'll see the purpose of this event.
By the bootstraps, take care of yourself, and that's how we are in the U.S.
So you see, we've come to the end of time, end of our time now. But you see, the main purpose of this 90 minutes was to make the UK treatment professionals feel a little bit better about the system we work in. There actually is some great stuff in that we should learn from America, and a lot of these good ideas are coming over. But the fundamentals is, as Nick has nailed it there, the fundamentals we got used to is that basic safety net. Any part of this country, you can walk into your drug and alcohol service and talk to somebody and see where it goes from there. It's not in place in most parts of the world, I've got to say. Okay, well, thanks for your time.
Great job. You guys did a great job. Yeah, you guys did.